Thank you. I got asked to speak on a difficult topic, which is performing outpatient EUS in the ambulatory setting. Is it a worthwhile endeavor? So, as I started to research about this topic and thought about what it is that I'm hoping to answer for you, I came with a lot of curiosity and hopefully some open mindedness. And as I found myself working on some of the details for this, I found my opinion to change about this subject significantly. So hopefully, as you listen to this, you'll find some practical takeaway values, and you may see some future inroads for application of this technology to a larger cohort of patients. So, a little background. This is extremely important for those from the United States. There have been recent changes in the CMS policy. This is just happening in the past 3 months. And what has happened in specific with some of the passage of the new big bill and things specific to CMS policy, they've now changed what is thought to be allowed in an outpatient prospective payment system for ASCs. This affects multiple surgical fields. So, for example, orthopedic surgery, a lot of things that were happening in the hospital now are allowed to happen outside the hospital. This also affects cardiology and, of course, endoscopy. So, this is a big deal. I think what this will lead to later on is a reduction of out of pocket costs for Medicare beneficiaries. So, what this will mean is that Medicare used to regulate and say, we'll only pay for things in the hospital. I think in the future, things that are done in the hospital are now thought to be safe and then potentially could be offered in an outpatient setting, which will force us to think about what do we really need to do in the hospital, and is it worth the additional amount of expense to the patient? It also increases hospital accountability and transparency. It safeguards us in the Medicare Trust Fund from waste and abuse, because as you know, anything we do in the hospital comes with a big charge to the patient and to the healthcare system, which perhaps is unsustainable in the future. So as you think through this talk, I want you to think about these potential passages of these laws and how they affect things. In specific, EUS, ERCP, and endobariatrics, as well as other endoscopy procedures, have been included in this bill. So they are specifically calling out these types of procedures. So, what does this mean for patients? And what are the potential implications for practice of endoscopic ultrasound and now in the ASC? This certainly changed my mind when I approached this topic. Coming from Indiana, where how I was trained on EUS, it always happened in a hospital-based setting, typically a tertiary setting. This may change in the future. So the first question I ask, and again, this may be my own bias through Indiana, is this safe, right? Is this something that we can safely do in an ASC setting for patients? Because no matter what the cost efficacy is, we wouldn't do it if it's not the safest thing for our patients. And so there is some literature on this, and I will continue to look at literature, think about the quality of the literature when I make decisions for our patients. So the first studies actually go back to 2014. These are retrospective studies. They're published studies. You can see the authors below. This was first shown at ACG. So they took a look at a cohort of about 885 procedures, so pretty far large volume. They're all done with propofol. You can see the ASA grade is 3 or less, 2 experienced fellowship trained endosonographers, and you can see the major adverse events requiring hospitalization. And they compared those to the same cohort of patients, so same population getting colonoscopy, and they found that the time satisfaction required to do an EUS as well as the outcomes for these procedures and patient satisfaction scores were the same. This was retrospective study, but nonetheless, it was a meaningful first step into this arena. 2016, there's now a prospective multi-center study. This looked at the feasibility of both ERCP and EUS in an ambulatory care setting. It was all data collected and then looked at all the way to 2 years out. 375 patients. They were divided between inpatient and ASC and put into 2 different arms. And what was interesting is these patients were sicker than usual. So they had a higher ASA score and they had other comorbidities as well. And you can see how many of them were divided into the ERCP and the EUS arm, with the EUS arm having 277 patients. And when you take a look at this, what they found is for adverse events in EUS, there was no increased or elevated risk. And in specific, they called it a 3% risk of bleeding, pancreatitis and 1% of bleeding. So now you have some prospective data that says that maybe you can do this safely in an ASC. And this is quite some time back without the advent perhaps of FNB and some new needles. Then we specifically looked at liver biopsy. So I like this. This is a much more recent data, 86 patients. Again, retrospective review of prospectively collected data. And they looked at, can we do an EUS liver biopsy on these patients? This happened to be the same cohort of people who looked back in 2014 on just EUS alone. And again, they found that it was safe, feasible, and comparable to what they were experiencing in the same patient population when they did this in an inpatient setting. So safety seems to be okay when I summarize all of this. So what is safe? Diagnostics are safe. So you notice we mentioned FNA. Those included FNA in both of those studies. And now FNB, specifically for liver biopsy. They use propofol for all these patients. It is like most things operator dependent. So these are all experienced endosonographers. What they did not address are some of the things you're seeing today. So these are therapeutics, specifically drainage-based procedures. And I think one thing that we can always think about is don't be a cowboy. So what does that mean? If you're doing drainage-based procedures, it's not just you doing the procedure safely, but it's also all the other people around you. So if you get into bleeding, you need to go for an urgent or emergent operation, you need to be in a setting where you have those other things to support you. But keep in mind, as was pointed out to me by actually some orthopedic colleagues and cardiology colleagues who I talked to about this, they're doing now EP procedures in ASC settings. So the things that we think of as safe or unsafe, they look at us and kind of laugh at it a little bit. So it is something that we need to consider as we move forward. So then the next issue in the United States is cost and reimbursement. Can you do this sustainably? Is this something that you could potentially sustain the ASC or your practice around? So this gets a little bit more tricky. Again, if you look at the one study in ACG, that was the same study, same cohort, different population. And what they did was they looked at what is the profit. So if you look at the Medicare cost savings, there's actually a cost savings to Medicare. So if you tie it back to the passage of the new bill, Medicare is saving money if you do this on Medicare-based patients. And this is about the net profit that they calculated in 2014. What's surprising is things have changed. You actually are getting a better reimbursement for the facility fee and the physician fees. So let me take you through a little economics or how we would look at this interplay. First, you need capital. So here's the capital costs for different manufacturers, Olympus, Fuji, Pentax. And down below what you're seeing is a newer technology called endosound. So endosound is something that actually fixes onto your regular upper endoscope and allows you to perform linear array endosonography. It has a Medicare traditional pass-through code. And that code allows you to actually even engage commercial payers, and most commercial payers pay for this. So that cost actually is even significantly lower. You don't necessarily need a high-end processor. So if you look at a Fuji processor, this is the listed retail amount. You can use the entry-level processor and perform all of these procedures potentially in ASC. Again, endosound's even less expensive than that. So then here's the needle costs, because you need to factor that in. FNA, FNB, these are, again, retail costs. These prices can be lower. They're not going to be higher, but they may be lower depending on your overall purchasing agreements with these individual companies. And then specifically for endosound, they're microtech needles that have reduced length so you can pass them through an upper endoscope. And you can see what the needle costs are there as well. So then it comes down to essentially a math equation, right? So this is what you get paid when you do the procedure. What this is the most of the latest 2025 facility fee, and then there's also a payment to the physician as well for the procedure. So you can see this being called out. So the ASC fee, as you can see right now, is significantly less than if you do the same procedure for the same patient in the hospital. But I think the purpose of the new bill is to try to start to equilibrate some of these costs to Medicare so that the system itself can be sustainable. So what do the economics look like? And, just from my background in doing a lot of healthcare administration, if you took at this, I look at what are fixed costs. Fixed costs are the cost of the capital investment, as well as overhead from your facility. So if you're doing an ASC, you're going to have anesthesia, you're going to have staff, you're going to be paying rent on that facility. Then if you look at a per care cost, you use Medicare numbers. So I just gave you Medicare numbers. The facility fee has gone up to $864, plus the physician gets paid $251. So that's the total amount of money that you're going to take in. You then subtract the needle costs that I gave you, plus the fixed costs that I outline above. You also will get some pathology reimbursement. So this is something that I looked into also for this talk. If you do rapid onsite, which you can do, before we didn't do it, but there are some centers that actually the pathologist is employed through the GI group. They can sit there by the ASC. They can come in and give you rapid onsite. You can bill cytology charge for the rapid onsite, and then you put the rest in formalin and you bill a surgical charge like you would for forceps. If you don't have rapid onsite, you would do an FNB only and you would bill just a surgical charge. So you put all this together, you have your facility plus your physician payments, you have your needle and fixed costs, and then you also get some money back for pathology if you have that in your facility. And here you can see rough ballparks of what all of this would look like. You obviously can depreciate the equipment over a period of time. You could rent the equipment, so you don't necessarily have to come out of pocket for those costs. This probably makes it much more economically sustainable than even 2014. A little bit on pathology. So this actually changed my mind as well. I'm a big believer in rapid onsite. Everywhere I've been has had rapid onsite. But the world has changed a little bit, right? So for solid lesions, maybe it's a disadvantage if you don't have a rose. But for now, we know that you can get an 89 to 94% yield doing 2 to 3 passes with a fork tip or Francine needle. This is published data. Everyone's can do this. So you don't necessarily have to have rose. Cystic lesions, it's just sending fluid to the lab. So you could do pancreatic cysts in your ASC as well. A little bit about the advantage of the ASC. So similar time to colonoscopy, 30 to 45-minute blocks, unless you're Anand Sahai, who yesterday said he can do this much faster. Physician time, so no need to drive to the hospital. It can be worked into the rest of your cases. Remember, when you're working in a hospital, you get bumped, especially if you go after hours. You're fighting for block time, and there's inherent inefficiencies. What about future directions? So where do we go with this? So I think first and foremost, let's override the new law and the new things passed by Medicare and think about the future state for this. The future state may be that payers now are going to follow Medicare like they always have in the past. Medicare may be more receptive to thinking about doing these procedures in the ASC. They may actually be able to negotiate with these payers. So a private payer will say, now we know it's safe. Medicare has allowed for this, and we're going to pay X amount to the hospital. You can negotiate with them perhaps and say, look, we'll do this for 2/3 of the price of the hospital. And you can start to do this safely, which we know. And these are the lesions that I may select: subepithelial lesions, EUS liver biopsy, all sorts of masses that don't require fiducials, because if you look at fiducial costs, it's quite expensive, and pancreatic cysts. I think things like therapeutic drainage procedures probably are off limits, right, for now at least, because of the supportive care needed and the other services you may have to call upon. And some centers can offer rows even if the pathologist is not directly there through either virtual, or they can have the pathologist on site. And increasingly, they're going to start talking about right place for the right patient. And so you're going to hear this in all sorts of health systems. I can tell you we're talking about that in Banner Health already. And what are the win-wins for the patient that make things economic and sustainable? So this topic that I was chosen to talk about has really kind of changed my mind and made me think about the equation a little bit differently. And I think that there's a potential future for the role of EUS in the ASC.